Hello, everyone. My name is Marianne. A warm welcome to everyone who's tuning in this afternoon, and thanks to Dr. Lindenberger for this talk on navigating medical decisions in ALS and getting the support you need. I invite everyone to put their questions into the Q&A box at the bottom of your screen, and we'll address them at the end of Dr. Lindenberger's talk. Dr. Elizabeth Lindenberger is a geriatrician, palliative care medicine physician, and physician at Massachusetts General Hospital. Throughout her career, Dr. Lindenberger has been a leader in geriatrics and palliative medicine education and developing ALS interdisciplinary clinical programs for patients with ALS in the VA system. She established the first ever interdisciplinary ALS clinics with embedded palliative care at the Washington, D.C. VA Medical Center in 2004 and at the James J. Peters Bronx VA Medical Center in 2009. As a palliative care physician for 20 years, she has dedicated herself to supporting patients with ALS and their families throughout the trajectory of their disease. Thank you. Dr. Lindenberger.
Thank you, Marianne, for that warm welcome. Just share my slides. And thank you to all of you for being here today. It is such a pleasure for me to be able to talk with you today. And I'm really looking forward to sharing them some things that I'm hoping will be helpful to you, and also to hearing what kind of questions come up for you. And we will definitely have time at the end for that. So today I'm going to be talking about navigating medical decisions in ALS and making sure that you get the support that you need. So what I'll be going through today are the following. The first objective is really for you to be able to describe the common decisions that come up in ALS. There are so many decisions that come up with ALS, but I'm going to pick a few that are ones that sometimes patients and families find stressful, and also sometimes just confusing. So one is going to be feeding tubes, another one is breathing support, and another one is hospice. You'll also learn today about tools that would help you explore and express what matters most to you as you're navigating all kinds of decisions. You'll be able to discuss how palliative care can help support you and your loved ones, and also to identify particular advanced directives, what advanced directives are, and particular advanced directives that can help make sure your voice is heard. And one of those is in healthcare proxy, and the other one is called a MOLS or a POLS, depending on where you live. So I'm going to start with a case. This is the case of Linda. Linda is a 61-year-old woman, interior designer, who's married. Her husband is Joe, and is the mother of 2 children. She was diagnosed with ALS a year ago, and it was really rough on her and her family, as it always is. But she's kind of gotten her mind around this diagnosis, and is functioning the best she can, and still enjoying a lot of things. And her family's really pulled together and has been really supportive of her, and she's doing pretty well. The struggles that she's having is she's a little bit weak in her legs, but she is absolutely able to walk. Her arms are a little bit weak, and she does need some help with dressing and with cutting food, though she can feed herself. And she's been noticing that she's having some difficulty swallowing, particularly hard, solid foods, but her breathing feels fine. And her numbers have always been good when she goes in. So these are the things that she's expressed to her family, and is also increasingly expressing to her medical team. So the things that she loves to spend time with her friends and her family. She also loves her garden. In terms of her hopes, she wants to live with the best quality of life that she can for as long as possible. And she's really looking forward to a trip for the birth of her first grandchild in June. In terms of her worries, she really worries about losing her ability to communicate. And she also worries about needing a lot of care. She says, I don't want to be a burden on my family. And that's something that weighs on her sometimes. In terms of her husband's hopes and worries, he says, I want her to be around as long as possible, and we're a team. So here are some decision points that are coming up for her now and that are likely to come up for her later as well. So right now, her doctors are starting to sort of talk about the possibility of a feeding tube. Later, they're going to be bringing up questions about should she start on non-invasive ventilation? And then later in her disease, she is wondering about whether hospice could be helpful, but that's way down the line. So right now, we're going to talk about the feeding tube. They're starting to mention this, and she's kind of feeling confused, which is normal. So let's talk about decision making in general in medicine. With that decision making ideally should be a shared process between a patient and family, or patient and whoever is important to them to be part of decision making. It's different for everybody. So what matters to me as a patient, plus information and guidance from the health team, right? Because they're the ones, who have the knowledge of kind of all kinds of things related to the illness and treatments. And then bringing those things together. What matters to me? What guidance I'm hearing and knowledge about the medical situation coming together to make shared decisions. So that's kind of the model we're going to be thinking about here. So that first part is so important, that what matters to me as a patient part, right? This is an example of a really nice workbook that comes out of Ariadne Labs and the Conversation Project. And the link is later on in my slides. But it's a whole workbook that helps people to think about what are the things that are important to me, because the more I understand and can really capture those things that are really important to me and matter in my life, and the more I can share them with my health team, the more we can work together to make a decision that's going to work best for me. So the first piece of sort of decision making is really understanding what's going on in your disease, right? So how do we make sure that we as a patient get the information that we need about our disease and what to expect? So I just want to make a few comments about this. Many people find it's helpful to know what to expect in their disease, right? Now, some people want to know less and some people want to know more. Some people, the way I think about it is, some people are like very detail oriented and want a lot of concrete information and all the details. And there are other people who are really more comfortable with the broad sweeps. So even that piece is really helpful to communicate with your doctors and your healthcare team. Like how do I like to receive information, right? And also knowing with ALS, the course of ALS is really quite variable. It's hard to predict, right? Because everybody has a different kind of trajectory and experience, medical experience with ALS. But sometimes the way that the ALS presents or the way that it's going can give some information for your doctors about what to expect in the future in terms of the course of your disease. And as I said, it's also it's really okay to say how much information you would like and how you'd like to receive it. For example, maybe you want certain of your loved ones there when you receive information. That's often really, really helpful, because sometimes when we're receiving information, it can be complicated. It can also be emotionally loaded for us because it's really hard stuff. And having more supportive ears in the room can be really, really helpful. So making sure you can advocate for this yourself to make sure that that happens. So back to this, what matters to you stuff, so here's some tools I included here for that there's some really great tools that can help you to really do that work of exploring and thinking about really in depth what's important to you in your medical care. So one of them is called Prepare for Your Care. And that is a website that is incredibly user-friendly, and you don't have to be like a big computer person to be able to navigate this website. It's pretty straightforward. It's something you can do with a family member, or you can do on your own. And it helps you really to think about, do some exercises to think about the things that are important to you. And also start to think about making some decisions, like thinking about a healthcare proxy or how to express your wishes to your doctor. The other one is from what I showed you earlier, the What Matters to Me workbook. And this is the link for it. It's under Ariadne Labs. And this is a really nice workbook that just helps you to explore what are the things that matter to me most in my life. And so that when I make medical decisions, these are the things I need to take into account, or my healthcare team needs to take into account. So I'm going to give you some example of some of the questions to think about. So one is, what would you like to know about your illness and what may happen in the future? What kind of information would help you make decisions in the future? What does living well look like to you, right? Because that can be different for different people. And then thinking about your medical problems, what are you most worried about? You know, we heard that Linda's worried about being a burden. She's worried about possibly losing the ability to communicate. That's weighing on her. What kinds of medical care do you want or not want? Okay, some people really have feelings about that, and some people have, are kind of haven't thought about that much yet. What do you think it would be like to share these thoughts with your family, right? So that's sometimes not so easy, but thinking about tools for doing that and talking to your family, and sometimes bringing your family to appointments and making sure your healthcare team is sharing things when your family is there, if that's what you want. And then if you all haven't already identified a healthcare agent, who would you want to fulfill that role? And we'll talk a little bit more about that later. So I want to introduce palliative care, because palliative care can be a helpful part of care for people with ALS. And not everybody is really very familiar with palliative care. Some people have really good knowledge of palliative care. They may have experienced it before, maybe with a family member, so they kind of know what it is. Other people have never heard the word before. And then there are people out there who have maybe a misconception of what it is. So I'm going to give you a definition. Palliative care is a specialized medical care for people living with serious illness. This type of care is focused on providing relief from symptoms and stress of illness. The goal is to improve quality of life for the patient and the family. So for many people with ALS, palliative care a palliative care doctor or nurse or social worker or team might be a part of your care, along with your usual ALS team, may be embedded in that team, depending on the clinic. Or it may be that something that you seek out separately as another add-on to your care. And I also put this website on called getpalliativecare.org, because it's a really nice resource for finding palliative care providers in your area. If you're interested in having this added support of palliative care, you can find out about local resources on that website. So palliative care, what does it look like? So it focuses on providing relief from the symptoms and stress of serious illness. It's provided by a specially trained team of doctors, nurses, and other specialists who work together with your doctors to provide an extra layer of support. And sometimes this is really just as much as kind of helping with coping when it comes to this illness, or coping when and navigating decision making. That could be a part of it. That could be all that it is in your case. Could also be symptom management. So the kinds of things that they will do is to focus on quality of life, is help relieve your symptoms and distress, help you better understand your disease and diagnosis, help clarify your treatment goals and options, understand and support your ability to cope with your illness, assist you with medical decision-making, and coordinate with your other doctors. So I'm going to pivot now and talk about some common decision points in ALS. Now, I feel like I could have made this list really long, right? Because there's so many decisions to be made in ALS, and it might be, should I join a research study, right? It could be, should I start that new medication that just came out, but we're not really sure, about the data, or I'm not sure that I want to take another pill every day or packet of this or whatever it is. And, so there are a lot of kinds of decisions, but I'm focusing on 3 today, just because I find that these are sometimes complicated ones, and ones that sometimes can cause some stress in terms of kind of navigating them. So again, feeding tubes, breathing support, and hospice are the ones I'm going to cover here. So I'm going to start with feeding tubes. What are feeding tubes? So they're also called gastrostomy tubes. They're tubes that go into the stomach and out of the skin of the abdomen. They're used when people have difficulty swallowing or they're losing weight related to the ALS, right? The most common type is called percutaneous endoscopic gastrostomy, or a PEG. So you may have heard the term PEG. That's what it stands for. It's a lot easier to say PEG than that very long name. And the alternative is called a RIG, or radiological insertion of gastrostomy. Sometimes that's used when it's felt that the PEG procedure, which is normally a very low risk procedure, some people who have developed a lot of breathing trouble with ALS, it may be deemed too risky to do the PEG, and then the RIG is done because you don't have to have as much sedation with it. So in terms of the PEG procedure, this is what happens. A tube is put through into the mouth while the patient is sedated. And that is basically an endoscopy. So like if you've ever had, it's, like a colonoscopy is from below and an endoscopy is from above. If you ever had an endoscopy, sometimes people have them if they have stomach problems or looking for maybe an ulcer. That's the same thing, except in this case, the camera goes down into the stomach and an incision is made through the abdomen while the patient is sedated, and a feeding tube is inserted through the stomach. And the point of this is so that specialized liquid feedings can be put through the tubes daily to help maintain your nutrition. This is just a picture kind of what it looks like. So, one of the things I think sometimes people worry about is like, is everybody going to know that I have a PEG tube, right? Because it sounds kind of big and invasive, but they're not enormous, and actually they don't show under your shirt. This is what it looks like basically, and it would be covered by your clothing. So let's go back to Linda as she's thinking through these issues. So because she's having some trouble with swallowing solids, she's still eating and some things are going down just fine, but she's having trouble swallowing solids and she's losing some weight. So her doctor wants to bring up the possibility of a PEG. So he tells her the benefits of a feeding tube, and he says, you can still eat by mouth if you have the feeding tube, but this just offers the option to supplement you later if your swallowing gets worse. And it is safest to do it now while your breathing is still strong. So what he's actually suggesting in her case, because she's still able to eat pretty well, and her speech and swallow therapist in her clinic has helped with giving her some great tips about managing food consistency, like maybe not so much steak, but instead maybe the spaghetti with the bolognese that's wet, that's going to go down a lot more easily, right? Things wet, soft foods. So she's actually been doing pretty well with that, and she probably wouldn't need supplementation quite yet. But what her doctor is suggesting is that then put it in now because it's safer now, and just flush it every day once with some water to keep it open. And then when it comes time that you might need some supplementation with liquid supplement feedings, then we'll have it in. So Linda decided to get the feeding tube. And this is what she said. She said, at first, I didn't like the idea of a feeding tube. It reminds me that I have ALS. And that feels also like a big step. But I really want to live as long as I can and continue to live my life as normally as I can. And my doctor's telling me that I can still eat my meals with my family in this way. And I also know I have a backup plan. So some common questions about feeding tubes. So can I still eat by mouth? Yes. So this is one of the most common misconceptions, because there are diseases and medical conditions where we put in, where when we recommend a feeding tube, we recommend against any oral feeding because it's considered too dangerous. For most patients with ALS, that is not the case. Now, the exception would be some patients with bulbar onset ALS will completely lose the ability to swallow and will not be eating by mouth. But I'm going to say the majority of patients can continue eating by mouth, and the feeding tube, it just provides extra support. So a person will eat their meal, sit down, eat their meal, but whatever they are not able to eat, then they can supplement with feeding tube. So it really takes the pressure off of eating, because you don't have to get all your calories in at that meal. You can just eat what you can eat and then supplement. Okay, another common question. My doctor says my breathing is getting worse and I should have a feeding tube put in soon, but I'm still swallowing okay. So I kind of covered this a little bit in my case, but the important point here is that the PEG procedure is most safely done when breathing function is still strong, right? We want it to be a safe procedure. It's a really safe procedure in that setting. It can be a little bit more dicey if somebody has significant breathing trouble from their ALS, because you have to do conscious sedation. And that's a little bit risky when somebody's breathing function is impaired. So we recommend it early placement before you need it. Of course, when there's already some signs of swallowing trouble. You can have it placed and just not use it until later, and it just gets flushed daily with water. So I'm going to switch gears now and talk about assisted ventilation. So how does ALS affect breathing? Well, it causes weakness of respiratory muscles in the diaphragm, right? So, ALS affects nerves that innervate your muscles, that stimulate your muscles to move. And the breathing muscles of breathing are no exception, and the diaphragm is no exception. So the lungs themselves are fine in ALS. There's no problem with the lungs. It's the muscles around the lungs that need to do the work of breathing. They can become weak. So early symptoms of trouble breathing that your respiratory muscles are affected. Some of the early symptoms are morning headaches, and that has to do with some impairment in breathing at night, and shortness of breath with walking, or shortness of breath with lying flat. So those are some of the early symptoms that we ask about. When it becomes worse, people start having shortness of breath that could be at rest, could be anytime, but these are the early symptoms here. So what is assisted ventilation? Well, it is respiratory equipment that helps your body to breathe more efficiently. And what types are there? There are non-invasive types, and these are the most commonly used. And those are sometimes you may have heard of them as BiPAP, or even a Trilogy is a brand of a machine that's actually a non-invasive ventilator. There's also invasive mechanical ventilation. And this is where a person who's in the very end stages of ALS, where the breathing is extremely impaired, will go through a surgical procedure to have a tracheostomy placed, which is basically a surgical incision in the neck. And it's called invasive because the tube goes directly into the trachea, and the person is attached to a ventilator, essentially usually 24/7 or eventually 24/7. So let's talk about non-invasive mechanical ventilation. There are so many types of machines and masks, and any good respiratory therapist can help you find the one that works for you. And that's really key. So again, we recommend using non-invasive mechanical ventilation as soon as you have impaired breathing, because it helps people to live longer and feel better. It's the best palliative care intervention type of intervention we could possibly have, right? You live longer and feel better. And we recommend using it starting at night. While you're sleeping. Sometimes people will try it out with a nap, when they're getting used to it, because sometimes it can feel kind of funny at first, and it takes some time to get used to it. But we want to get to a point that people are using at least 4 hours during sleep. And if you're not finding it to be comfortable, usually there's another mask that can be used that it will be comfortable. Again, helps people live longer, helps with symptoms, particularly symptoms like energy, fatigue. It makes people feel more energy, less fatigue, and it helps improve shortness of breath. I mean, the amazing thing is that even if you're just using it at night, you'll feel less short of breath in the day. These are some pictures. You can see on the one side that it looks like just a nasal mask. There's also a full face mask. And then the other picture shows what we call nasal pillows. So just two very different types of masks. And then this is the most invasive type of ventilation, a tracheostomy and invasive mechanical ventilation. And that's used when a person's primary goal with ALS is to prolong life. It does not slow down the progression of ALS. It is not the majority of patients who choose to undergo invasive mechanical ventilation in advanced ALS. In this country, it's about 5 to 10% of patients who choose it. They are generally, if you look at the data, more likely to be younger, more likely to be people with young children. The other 90 to 95% of patients in this country choose comfort-oriented care at the end of life. For people who choose invasive mechanical ventilation, and when we discuss this choice with patients, we talk about the very kind of how this would look right after undergoing this. And it does require 24/7 caregiver support with the ability to kind of hear the ventilator alarm, suction, frequent suctioning. And for some patients, this can be expensive because this is not sometimes a family can provide all of that care, but oftentimes really what's needed is private care, home health nursing care, and that can be really expensive. So many people end up really needing a nursing facility who make that choice. Not everybody, but for some people, that's what that's what is going to work the best. So lastly, I want to talk about hospice. So what is hospice? So hospice supports you to make the most of precious time when time is short. And the term hospice is frequently misunderstood and is equated in many patients' minds with imminent death. But on the contrary, we really like to bring hospice in before the very end of life, right? And it's hospice, and the point of hospice is really to help people with quality of life on the wishes of the patient and the family, and on easing the distress at the end of life in the months preceding death. And this is just a site, Caring Info, that can give you some information about, I put the site at the bottom here, about hospice. So I want to just share some common questions that I hear about hospice in case any of you kind of have questions about these things. So who is eligible? Well, anybody who has ALS, who's really in the advanced stages where life expectancy is most likely less than 6 months, is eligible. Does that mean that every patient referred to hospice is going to die within 6 months? Absolutely not. It's possible the person could die in 6 months. And that essentially really means hospice eligibility. And what does hospice provide? So hospice provides care focused on comfort, quality of life, and avoiding hospitalization. The care occurs in the home or wherever you live. So it could be a nursing home or assisted living. Wherever a person lives, that's where hospice care happens. There are also inpatient hospices, but that's a little bit more of a specialized thing. And I won't go into kind of what that looks like or payment looks like for that, but that they do exist. But the vast majority of care happens in the home. Care is provided by a team of clinicians, a nurse, social worker, chaplain, home health aides, for example. The most and how this really looks for a patient and family is generally the patient, the main contact is an RN who does typically at least weekly visits and sometimes more to the home, and that becomes the person, the patient's and the family's point person for hospice. There's also social work support, chaplain support, and home health aid support. And all of that is free of charge to the patient with the hospice package. Now, the home health aid support is not 24/7. It is generally only a few hours a week, but it can be really helpful with bathing or other kind of care needs to just help out the patient and the family at home. They're there to manage symptoms and offer emotional support for the patient and family. One of the things I say about hospice that's really unique and wonderful is that it's not just about the patient, but actually the unit of care for hospice is the patient and the family. They are actually treating everybody at home. And that is literally like defined in the Medicare hospice package. So it's like the whole unit is receiving care. It also offers a 24/7 phone line to call with questions or in an emergency. I cannot emphasize enough how important this piece of the hospice benefit is, because imagine that you're a patient who has very advanced ALS and you've decided, I don't want to go back to the hospital if something comes up, I want to be home. But sometimes emergencies come up in the middle of the night. And if you don't want to go to the hospital, but you still have an emergency, you still need help to take care of it, right? And so it's not enough just to say, I'm not going to call an ambulance, but like, who do you call? So you call hospice, and they can walk you through exactly what to do. 24/7 support. And they offer medications and equipment that's also free of charge as part of the package to help, and medications to help with the symptoms related to your diagnosis. And they send all of these directly to your home. So you're not dealing with pharmacies anymore. It's one pharmacy through hospice. How's it paid for? Usually through Medicare, Medicaid, or private insurance. There's also charity care for people who don't have any of those things. The VA also pays for hospice. I mentioned advanced directives earlier. Advanced directives can help ensure your wishes and decisions are carried out. So advanced directives, everything I've talked about so far is not about advanced directives, right? That's just about navigating decisions and making sure that what's important to you is reflected in the decisions that you're making with the guidance of your health team. But advanced directives are legal forms that help to make sure your wishes are met. Okay, so they can be a supplement to all this other stuff I've been talking about. So one of the things that I think is probably most important in terms of the legal forms is what's called the healthcare proxy. And in some states, it's called the durable power of attorney for healthcare. This is a person that you name to make decisions for you if you become too sick to make decisions on your own, right? So most patients have capacity to make decisions throughout the course of their illness. But if somebody becomes very, very ill and they're not able to make decisions, we as the health team need to know who to talk to, right? And certainly, many states, including New York State, have a list of sort of a hierarchy of what we call next of kin, so that if you don't have a advanced directive, like we go to the spouse first, then the adult child, but maybe that's not who you want, right? So the safest thing to do to make sure the person that you want to make decisions is actually the person that your healthcare team would call in an emergency, or would help make decisions, is to fill out a form. And it's really easy to fill out because you don't even need a lawyer, although you can do it with your lawyer, but you can go to go on the website. If in New York State is nyc.org, I think, or New York State.org, and just Google healthcare proxy, and you can print the form. And all you need is you just name the person you want to be your proxy, and you name an alternate if you don't have to, but I recommend naming an alternate as well if that person weren't able to make decisions, or deferred. And then you just need 2 signatures of witnesses to your signature. They just can't be the person that you've named in your proxy. But you don't need a lawyer. You don't need to notarize. Super easy. But also make sure you make copies and that your health team has them so that they know. And then the other one that sometimes is helpful for people with ALS, especially if you have really if you've made some decisions about things you wouldn't want, in terms of life-sustaining measures, this can be really a good way to ensure that your wishes are honored. So if you know, for example, that you would not want invasive artificial life support, this can be really helpful to complete. So for example, if you can say, do not intubate, do not resuscitate, as an example. That the important thing about that is that this is an order that can sit in your home. Sometimes people put it on their refrigerator or by their bedside. And then if you need to call an ambulance, they will come, and if they see this notice and that you say something like it says do not DNR, DNI, they will do everything to take good care of you, but they won't do those things that you don't want. And so that just helps to ensure that your wishes are met. This is just what they look like. On the left, you can see the healthcare proxy form, super simple 2-page form. And the pink one is the New York State MOLST form. They look different in every state. The New Jersey one is green. I think that one is the POLST. Anyway, but they're all very similar. So to wrap up, I'm going to summarize. People with ALS face several common decision points. And it's important to talk to your loved ones and your health team about what matters to you, because this will help guide decisions that are right for you, because everybody's going to be different in what is right for them. Palliative care is a specialty service that can help provide an extra layer of support at any stage of the disease, not just the end stages, but at any stage of the disease. Hospice can provide support to people with advanced ALS and their families. And particular advanced directives like a healthcare proxy form and MOLST forms can help ensure that your wishes are always honored. So I'm going to stop sharing here and open up to questions.
Wow. Thank you so much for that comprehensive presentation, Dr. Lindenberger. We have a few questions in the Q&A. If you have some that you've thought of, please type them in and we'll address them. Let's see. The first question is the workbook that you spoke about from ARIA Labs. Is that free or is there a fee for that?
That's free. You have to, I believe you have to register on the site, but it's free and not a big deal. I think they're just keeping track of how many people are using their materials, but all of their materials are free for anybody. And I think you just download it. And then the Prepare for Your Care is also free and a really nice resource.
Wow, that's exciting. Thank you. The next question, can you expand upon the 6-month prognosis for hospice? How is that evaluated? And what are the current FVC guidelines? You know,
such a great question. So the reason I did not put that in my slide because it's very complicated, and it's basically critically, it's complicated and uses words like critically impaired breathing. The bottom line is, because there actually have been studies that have shown that the hospice guidelines are just not that good in terms of predicting prognosis. The hospice guidelines, particularly for ALS, it's been looked at. I mean, they've done the best they can, but they are not the best. And that some people they would miss some people who really would need hospice services and benefit from hospice services. And so for that reason, I try to take them with a grain of salt. And, there is definitely wiggle room in there, right? In terms of because everybody looks different. You might be very, very impaired. You might be very impaired with your breathing, but you're still look good in other ways. Like you're still walking. And then I think sometimes I have found that sometimes agencies or providers won't, who are not ALS specialists, don't know to capture that, and that actually this is somebody who would really benefit from hospice services. But the bottom line is anybody who has pretty impaired, less than 50% FVC, I'm going to say, pretty impaired breathing, and really has the need, and where it meets their goals of care, it is appropriate to make a referral. And, if the worst thing that happens is the hospice intake nurse comes and the team reviews it and says, you're not quite ready, you don't quite meet our criteria. And then they come back a month or 6 months later, right? It's okay. You might as well try.
Right. So pretty much then, if a practitioner believes that you're hospice eligible, that's often enough.
Totally. Absolutely. Because the other thing that happens is once you're in hospice, you can stay as long as you're still needing the services and getting worse. If they can show that you're just, and the thing about ALS is, yeah, it progresses at different rates, but it always progresses, right? I mean, and so most of our patients don't end up being discharged from hospice because they've because suddenly they've decided they don't qualify anymore. Like it's, yeah. So yeah, if I always say to providers, if you think it's time for hospice, have the intake nurse come out, make a referral, check it out.
Agreed, agreed. One comment was, in New York State, arbitrary general guidelines we found for hospice eligibility with PALS is being bed to chair and having an FVC of low 30s or less. It's one of the practitioners. But,
Yeah. I mean, do you have thoughts about this, Marianne? Have you had experiences?
oh, sure. Sure. You know, we would, you know, in our practice, we use 40% of an FVC as a very soft, very soft guideline, you know, and sometimes it's less and sometimes it's more. And, you know, it's your feeling and the family's feelings, you know.
That sounds very right to me. And yeah, and that's right. You know, and I think why this has been a little bit of a moving target too is that for a good reason, that one that we should celebrate, which is people are living longer with non-invasive ventilation with low FVC, right? So that's a good thing. And but also there are a lot of people who could benefit from the support of hospice services. So I just say, you know, on the advocacy side, like try for it, because it's just more service, right?
Right, right. It's just always difficult when a family will call and say, we need more help, so I need hospice. So, and that's so difficult. It's just so difficult if that's the only parameter there is.
I mean, we could go off in so many directions in terms of the healthcare system and like how we need more resources to help people at home, right? But this is we just do. But because they are limited and it's hard to find, this is one that we need to advocate for our families whenever we can get it.
Absolutely agreed. Another question is, are decisions about getting a feeding tube or getting a trach reversible?
Sorry, could you repeat that?
Are decisions about getting a feeding tube or getting a trach reversible?
Oh, sure. All decisions are reversible in this realm, right? Absolutely. I think that's a really important point. In fact, I'm going to go further and say it's pretty normal to change your mind many times, right? Like actually that's being human. So yeah, you know, and could you decide to put a feeding tube in and then take it out? Yeah. Could you put a feeding tube in and not use it? Yeah. Could you decide to get a trach and see how it goes and then withdraw yourself from the ventilator? Yeah, people do that with some regularity because I've had many patients. I'm not gonna say many because I don't have a lot of patients. That's a small percentage, but I've definitely had a handful of patients who wanted a trach, lived on a ventilator for a period of time, really felt they had the quality of life that they needed for that period of time. And then as the disease progressed, no longer they felt that they had the quality of life they wanted. And so the decision was made to turn it off. So yes, decisions it's a very fluctuating and a kind of thing that, and something that we sort of can change over time.
Right. Thank you. Do you need to have a MOST form if you have an HCP?
So yes, nobody has to have a MOST form, right? But I'll tell you how it can be helpful and how it's totally different from an HCP. So in most states, perhaps everywhere, if you call an ambulance, they must do everything to keep you alive. And they follow a protocol. And even if your healthcare proxy, you have a healthcare proxy and that proxy is there and says, that's not what my spouse would want or my mother would want, in many circumstances, they still have to do those things under their protocol. So that's the whole point of where both become really important. Everybody should have a healthcare proxy. You and I should have healthcare proxies. Everybody should have one. It's just a good thing to have, right? Because nobody ever knows what's going to happen to them, right? Whether or not you have ALS. But a MOST that is really important if a person with ALS has actually has made decisions about about care they would not want to have, treatments they would not want to have. That really should be documented in a MOLST and kept at a place at home where paramedics could find it.
And are there palliative care physicians in the community as well as in the hospital setting?
There are more and more. There can sometimes be hard to find. Palliative care as a field started in a hospital setting, right? That's just where it was born as a field. But palliative care is really growing in the community setting, both in ambulatory clinics and also with home-based palliative care programs. There are a growing number of home-based palliative care programs. They're not everywhere, but more and more we are seeing them. So getpalliativecare.org can help you find whatever is available in your area.
Perfect. At the moment, there aren't any additional questions, but if you have any final thoughts that you wanted to share before we wrap it up for today.
I just want to say thank you for having me. And although I can't see all of your faces, I know you're there. And I'm just, I'm really honored to have had the chance to speak with you today, and doing this kind of care really just helps me gives me such satisfaction in doing my work. So thank you.
No, thank you. This was such a wonderful, comprehensive presentation. Gave us a lot of food for thought and answered a lot of questions. So thank you so much. For everyone else, the next talk is at 3 p.m. Practical tips for travel. And we hope to see you there. Thanks again.